Good morning, folks. If you guys can take your seats, we'll go ahead and get the conference started. So good morning. My name is Chris Lassar, vascular surgeon here in Chattanooga, Tennessee. I want to welcome everybody to the Faces of PAD conference. This is our 5th year running now since we started the conference, and I'm surprised at how it continues to grow. Both locally and through the virtual connections that we're supplying to the people in our region and in our country as well today. Special thanks to speakers who are taking their time to be here on their busy schedules to educate and bring their various specialties to the general medical community here. The goal of this conference has always been to be inclusive of all specialties, to promote best patient care and how we do diagnosis and treatment, and look for better outcomes for the folks in our region. So special thanks to CSI Cardiovascular Solutions as well as BD for their support of the conference. This allows us to provide 8 hours of CME that is free to all the participants, either on site or virtual. I've been informed that the virtual side of the CMEs can be claimed as well, and then the speakers are being recorded so that for the next 30 days people can still view the recordings and gather that CME. This is supplied by the Tennessee Medical Association, and we're appreciative of their support for that. So I could list all the doctors. It's quite a few, but I think what we'll do is what I'm going to ask the speakers is that they introduce themselves, simply your name, your practice, what you love to do, and we're going to start off. We're going to start off the program with I call them my dream team, but how do we optimize our health in 2022? And Ed Jones is going to kick this off, and we're looking forward to hearing his wisdom. Ed?
Thank you, everybody. This is my 5th year to speak here, and I'm always very gifted and really and we're just honored that people would ask me to do this. Especially, I value Dr. Lassar, his wife Tracy, immensely for planting seeds in this community that's a little bit outside the norm. We're talking about engaging patients for change, and Tracy asked me to talk about defining holistic wellness. Well, you know, the definition of holistic is characterized by the treatment of the whole person rather than just the symptoms of the disease. And I think we're all very clear on what that means. But in my world, that has been my whole life. I've been doing own nutrition for 43 years. I have, my passion is what I do every single day. I don't have to go to work. I get to go to work, and that's how I feel every single day. You know, the percent of people seeking alternative health care is about 36% of the people using right now complementary and alternative options for their own health. So physicians and healthcare practices may not realize this because the patients are probably not being honest about it. They're doing it on their own. So we know that 1/3 of the population is seeking more holistic care. Now, as far as dietary supplements, right now we're at an all-time high. We have 78% of the population that is using nutritional supplements. And I want to dispel one myth very quickly, the myth that it's an unregulated industry. Completely myth. I've been in this business 43 years. The FDA has been in my business countless times. It has removed so many products. When I say so many, dozens, not thousands. And also, if there is dangers to the public, they act very quickly in order to do something about it. However, it can never be approved as drugs because the approval process cannot approve multiple compounds like you would in a nutritional supplement. They have a broccoli extract might have 43 compounds. Well, that's not standardized, so it can't work that way. So what is the holistic medical model? And really engaging interested patients for your positive outcomes. And I like the word interested patients. You know, people coming into nutritional world, they are interested. People coming to traditional healthcare, I would say 50% are interested and 50% simply aren't. As much talking about diet and lifestyle that you can do, it's a sad place, and I think we all agree. A lot of people want the magic pill. They want to just get better right now and not worry about the long term. And we have to meet people where they are. If that's where they are, that's where they are. But we do have a growing group who wants to do more than that. Now, for a healthcare practitioner to embrace holistic wellness, they have to do a little bit of their own work. And when I say that, you have to be able to help the patient create a team approach. A patient comes to you with the significant issues of not life-threatening, but things that are lessening their quality of life. Insomnia and aches and pains and this and that. You have to help them find a team, other people who might help in the regard of improving their health. And that could be from acupuncture to massage to a physical therapist to just all the people, nutritionists, diet coaches. So you have to figure out who is your trusted partners in that. And certainly Nutrition World can be part of that because we have 17 practitioners. We do blood testing through Be Well Labs every Tuesday and Thursday. We empower people is what we do. And certainly have two new people, Josh and Dr. Johnson. They're wonderful additions to Nutrition World. And those people who want holistic, they also want to be minimizing the use of pharmaceuticals. It goes with the territory. So the healthcare practitioner must be aligned with that path. Now, going back in history, we know Pasteur and Claude Bernard. It's very interesting because they were very giants in the scientific world in the same time together. They were friends, they debated constantly, but they had two totally different philosophies about health. And certainly Pasteur, pasteurization, vaccines, all the things, and germ theory was wonderful. It changed the world, but at the same time, Claude Bernard had the theory of the terrain. What does that mean? I think COVID has taught us what the terrain really means because we saw what happened. People who are weak, people who are not optimally healthy, people who have comorbidities, they were the ones who suffered the most. If we can build people's terrain, then they're going to have far better health. And that doesn't always come unless we focus on that particular philosophy. In fact, supposedly that Pasteur on his deathbed recanted and said the terrain is the most important thing. Now, mitochondrial dysfunction, to me, is what I call the terrain. The terrain was the old word. To me, it's mitochondrial dysfunction. And we learned in Biology 101, the nucleus is like the centerpiece of the cell. It's not. It's the mitochondrial function. Mitochondria is what produces energy in every cell. As soon as that energy is decreased, disease becomes more rampant, quality of life decreases, and cancer rates and all the other diseases go way up. So mitochondrial dysfunction from every aspect is what I feel that we need to focus on, again, which is the terrain. That's what nutrition focuses on, lifestyle, everything else. It's not treating a symptom, it's building the resilience within the human system. Now, Nutrition World has, again, 17 practitioners. I've set it up to be a wellness complex these days. It certainly isn't just a nutrition store, it is a wellness complex. Why do I do that? To empower people. And we have so many physicians and nurse practitioners who now shop with us on their own, and a lot of them aren't feeling comfortable with advising patients just because of the system at hand and who they work for, but it is growing. This is not something that's going backwards, it's only going to go forward. And I want to help this community individually and professionally to find the connections that they feel worthy and confident of in order to help the patient put a team approach together. Now, mitochondrial function and optimization is my personal life. I think that that is the way that I will age gracefully. And Father Time is pretty dang cruel past 40, there's no doubt. I'm limping around with a little bursitis, but other than that, I'm really good. But, you know, the wrinkles are coming, the this and that. It's just a fact of life. But can I slow it down? Yes, I can, and I can do it through mitochondrial support. And when you talk about that, that involves a lot of stuff. There's not a magic pill, but it can happen because we see it, the studies are out there now, and I love and I read every single morning for 1 to 2 hours, anything new in the nutritional research area. So I put together kind of my own plan. That doesn't mean it's your plan. It doesn't mean that I'm right, but it's the plan that I feel confident with that will increase and keep me at the optimal level that I am. And it's focused on mitochondrial support. What I do, weight train 5 days a week. You know what, aerobic stuff is great. Weight training is the currency that you will build for the longevity. The amount of people who I have counseled, which we have over 300 people a day at Nutrition World, who have come to me over the years that are weight trainers, who've had car wrecks, that lived through it they wouldn't have if they'd been training aerobically. They've had terrible sicknesses. They lived through it because they were strong and resilient in the gym. Yes, we need aerobic for the cardiovascular, but we don't build muscle on aerobics. Muscle is the currency for the longevity of this body. Healthy servings of clean, properly prepared colored plant foods. The earth gives us the medicines we need. It supports us with its primal knowledge and wisdom, and we just ignore it by going over here to Jack's and places and get junk food. It's right there in front of us, but we have to work to get it. I do believe in an ancestral diet. Ancestral and through my 43 years, I have, gone through every diet there is. There's not one you can mention that Edward Jones has not attempted for 6 months to a year. And I just have come to the fact that for my body, my metabolism, and mitochondrial support, the ancestral diet, what is that? Higher protein of clean protein foods, moderately low carbs. I do 60 carbs Monday through Friday, and I do 150 Saturday and Sunday. And they are made of good, healthy things, not just junk food. And then healthy fats with every single meal, including my breakfast drink. My breakfast drink is the kingpin of my life. I put together these three ingredients that create the best blood chemistry for the day. And I've learned one thing. If you have a perfect breakfast, you've set yourself up for success. If you have a breakfast consisting of this many carbs, you're toast. You are. The mitochondrial function is going to go down. Everything that you don't want inflammatory is going to go the wrong direction, and I don't care how good you eat lunch and supper, it's not going to fix it. You only have a start every single day, and if you will drink the drink that I put together, which you have to come to Nutrition World to talk about it because I don't have enough time here, it will make the biggest difference of anything. Donating blood. Too much iron is disastrous to our body. When I say too much, I don't mean middle in the range. You need to get down lower than that. So go to Blood Assurance and give blood if you're capable of doing it, especially men. I am a chronic insomniac. It destroys the health of the body to be lacking sleep constantly. I use this ring called an Aura ring. Again, this is one of the ways that I help empower people. I don't tell them how to sleep. I say, here's some tools. The Aura ring is a medical device, basically, that reads my oxygen, heart rate variability, REM sleep, deep sleep, and I've put together a plan based on, this dinner last night, I wonder why I didn't sleep well. Maybe that food bothered me. Maybe I took this supplement too late. Maybe I stayed up too late. Maybe I worried about something. So now I'm sleeping so much better. But again, educating or allowing the client, patient to be empowered. I wrote an ebook years ago, still very popular. It's, people Google Nutrition World Sleep, it's all you got to do, and they can download the ebook because losing the rhythm of sleep is not fixed by one pill because you lost rhythm. You got to build that rhythm back by a consistent plan, and I talk about it. And I certainly do a total array of nutritional supplements based on blood work. I really rely on the lab that we have at Nutrition World to empower people so they can get the kind of blood work they want to do. Now, just to give you an example of so many treasures that are out there in the medical and clinical world that are amazing for our health, that are not gimmicks, and this is just one of many. I'm just using this as an example. This is something that, and there'll be a flyer out there on the registration desk if you want to just pick up a small piece of information on this. It is, and I do believe science has discovered probably the most promising mitochondrial optimal health support in our lifetime, and it's called NAD. 67,000 clinical medical references to this one supplement. I do 300 milligrams a day. It's one single pill. Mitochondrial protection, incredibly effective. If all a person did was NAD and my breakfast drink, they would have a life that has been changed. Now, for you to help your patients, you have to have a list of resources. I love Life Extension because they have the protocols for the medical treatment of many diseases backed with every piece of research that no one can deny. Secondly, I love Today's Practitioner. It's a magazine online. Third, The Holistic Navigator is my podcast with 104 episodes. It's in the top 1% of the world podcast, which I checked yesterday, and it was last year. And this is what empowers people. Every subject is just a specific one. If you have constipation, if you have lack of sleep, if you have whatever, that empowers people. They need this information so you can feel confident giving it to them. TikTok, if you want to know about working out, I've got 3.3 million views. It's EdZone63, 50 seconds each time I talk about it, of how to work out in the gym to get results. A little more slanted to men than women, but it works for both. And then lastly, Dr. Perlmutter, a friend of mine, he's a neurologist, the Empowering Neurologist podcast, incredible for learning. So Nutrition World wants to be part of your team if you feel confident, and I'm certainly there available with my 29 employees who are very well trained. If you have any questions, we're always here to help you. Thank you very much.
Thank you so much. It's great to be here. My name's Allison Bailey. I'm a cardiologist at Centennial Heart. I'm going to be talking about the other 95% of people that we see that aren't that empowered yet, hopefully. But we're going to talk about choosing health and lifestyle choices you can control. And so I really think the key points that we all have to remember, whether we're counseling patients or ourselves, is the most important way to prevent atherosclerotic cardiovascular disease, which includes heart attacks, strokes, peripheral arterial disease, aneurysms, heart failure, and AFib, is to promote a healthy lifestyle throughout life. And there are lots of different components of a healthy lifestyle. And if you look at the metrics in the United States, we're failing at basically every one of them. And so we're going to briefly go through that data because I think we have to understand where we start before we can change how we change the health trajectory in this country. So all adults should be assessed at every healthcare visit for tobacco use, and those who use tobacco should be advised to quit and strongly advised to quit. So that's really the very first thing all of us has to do. We live in Tennessee where our rates of tobacco use are still very high. So if we think about the primary prevention of cardiovascular disease, the American Heart Association and the American College of Cardiology has a lot of great documents on this. But basically there's a variety of categories. We have to look at lifestyle risks, which we should do for everyone, whether you have heart disease or not. And then we should look at things that are specific to gender. So we've learned a lot about women in particular, things like adverse outcomes of pregnancy. Those really increase your cardiovascular risk over your lifetime. And so we should be assessing for that in every woman that we see. And I'll add that back in here. And then we have to think about socioeconomic status or the social determinants of health, because that really affects the health in this country. If you look at our life expectancy at birth, and where we live, our zip code is a stronger predictor of life expectancy than any other thing that is associated with us, any one metric. It's more important than our genes probably, because we tend to have the same lifestyle traits as other people around us. So mortality is higher in rural areas like Tennessee. So we have to acknowledge that, and that's probably for a lot of reasons, including things like we don't have good access to fresh food. There's not a gym everywhere where people can go exercise. Access to healthcare is different. And the gaps between rural survival and urban survival are widening. So we're not getting better at it, we're actually getting worse. And a lot of it's the social determinants of health. So I would just encourage you to think about that every time you see a patient. We know that cardiovascular risk factors go up as your socioeconomic status goes down, and it doesn't matter which risk factor you're talking about. Is it blood pressure control, lipid control, physical activity, diet? They're all worse as your income level goes down. And so that becomes really important, especially in the areas that we live in. And, you know, we'd been making a pretty good run on cardiovascular disease and decreasing cardiovascular disease. This graph looks at 1900 to 2020. But what we're seeing is an uptick in the last 3 to 5 years, and it's even worse after COVID. It's the curve has gone drastically up, but it's because our lifestyle has become poorer is probably a better word. And males and females, it's affecting all of us. This is just sort of a zoomed in view of what we just looked at. Peripheral arterial disease, which Dr. Lassar and his team do a phenomenal job of taking care of, is the next epidemic. We said diabetes was our last epidemic. We're all familiar with how fast those rates are growing. But peripheral disease is very underdiagnosed in the United States and is a strong predictor of mortality. And so we have to diagnose these patients, and this looks at age, and what you'll see is that African Americans have a much higher prevalence. So every patient that you see, we should be thinking about this, both men and women. And look at this, this is your ABI and your cardiovascular mortality. So it's basically a straight shot down. If your ABI is normal, your cardiovascular mortality is normal. As your ABI gets worse, your cardiovascular mortality goes up drastically. And so the American Heart Association has this concept of Life's Essential 8. They just changed it last year. It's always been Life Simple 7. But Essential 8 includes sleep, which, you know, Ed just talked about how important sleep is. Because there's now strong data that getting less than 7 hours of sleep a night is associated with increased cardiovascular disease occurrence and increased mortality if you have established disease. And so sleep's the 8th factor here. So if we look at the optimal health factors, it's a total cholesterol less than 200, it's a blood pressure less than 120/80, it's a fasting glucose less than 100, and a body mass index less than 25. And if we look at optimal health behaviors, it's optimal diet. And I think most established societies have gone away from recommending one diet because what we recognize is there's not a perfect diet for everyone. A perfect diet's a diet that's the best that you can accomplish with your financial means and your availability to get food and to make it the best for you. It's also associated with increased physical activity, no tobacco use, and then healthy sleep like we talked about. And so there's lots of information online at the Heart Association that you can give directly to patients or refer patients to about Life's Essential 8. So smoking's bad, we all know that, but if we live here in Tennessee, we have some of the highest rates in the country. The rates are still high, and in rural areas, rates of smoking are much higher than they are in most urban areas. So just a reminder to counsel your patients about smoking. Physical activity is very important, and physical activity is different than exercise, right? Exercise is when we go to the gym or we do something with the sole intent of improving health. Physical activity is every step we make in a day. So our Apple Watches, our iPhones, all the things that we use to track health. And so really we want to get more than 150 minutes a week of moderate activity. And it doesn't have to be all at one time. It can be, 10 minutes here, 10 minutes there. Or if you're doing vigorous activity, you get more cardiometabolic benefit from that standpoint. Weights are very important because of all the reasons we just talked about. If you look at physical activity volume, this is my favorite curve, and I draw it all the time for patients. So if you take a group, the highest bar over here, do I have a pointer? Who gets no activity, and you get them down here to some activity. Look how much benefit you get. If you compare that to the group that's already getting activity and you get them over here, or take this group and get them over here, you're getting to the flat part of the curve, which is where you get diminishing returns. So there's estimates, if we could get the group of people who do the least and get them doing something, we would affect outcomes on a population level far more than getting this group of people to here. So every time you see somebody, and I use this quote, 1 minute of activity is better than 0 minutes of activity. And your goal should be whatever you're doing to do more for most of our patients. If you look at the prevalence of who gets recommended levels of physical activity and weightlifting or muscle sort of activity, the majority of patients do not. The majority of people, not just patients, people in the United States don't get what they should. Less than 40% of individuals get anywhere near recommended amounts. And if you look at the guidelines for adults, it changes based on educational attainment. So if you look at your educational level from here, which is less than high school, to here, which is an advanced degree, the likelihood of getting recommended levels of physical activity goes down as your educational level goes down. This is the only graph I'm going to show that shows that, but every risk factor we're talking about is worse with low levels of education and finances. So remember that when you're counseling your patients. Again, healthy diet, lots of components. The American Heart Association says the first and foremost, it has to be appropriate in energy balance. So if your BMI is over 25, it's got to be a diet where you lose weight. There's only 2 ways to lose weight, and they both include consuming less calories and increasing the amount of activity you expend. It should be DASH type, which means low in sodium and processed foods. And it should contain lots of fruits and vegetables in a natural state. Fish, more than 2 3-ounce servings a week. Fiber-rich whole grains, which means carbs, but not processed carbs, really whole carbs. And then we should minimize sugar-sweetened beverages. I believe in whole food plant-based nutrition, which really is not refined. Majority of foods are plants, grains, and legumes, and there's no processed meats. And that's what I talk to people about. I think everyone agrees that processed meats are bad for us and are associated with increased death rates from all diseases. And then processed foods should be avoided. These are ultra-processed food, things that come in bags, boxes, and wrappers that you could not identify as food or what they started this world as. And there was a recent study that had over 40,000 adults, and it showed a 10% increase in ultra-processed foods was associated with a 15% higher risk of all-cause mortality. And so when you talk to patients and counsel them and your kids, if you have kids or people at your house, this is what we should be talking about, is trying to minimize this stuff. Red meat's also associated with increased mortality when we look through different studies. And if we look at healthy diet score, we don't do a great job. Less than 20% of Americans make a healthy diet score. We know that if you look at sodium intake and blood pressure, the lower your sodium intake, the better your blood pressure control. So this took people and put them on, that was on a regular sodium diet, which the average diet in the United States is about 3,000 milligrams a day. And it got them down to 1,500 milligrams a day, and you can see the difference in blood pressure control. And you know, if your patients are like mine, they tell you they don't add salt to their food. Well, the minority of sodium in our diet comes from added salt that we put on at the table. This, over 75% is added sodium, okay? So this is, this is in the food before we get it. So this is food that contains sodium. So it's mostly restaurant or processed food. And the blue is added salt at the table. So instead of talking to our patients about putting the salt shaker away, we should be talking about eating less processed food and less prepared food and making more meals at home. If we look at obesity, again, we're in the darkest color, which is not good. The South has an epidemic of obesity, and so we have to work on that. If we look at obesity among adults over 20, 40% of adults are obese. This is not overweight. This is obese, which is body mass index of over 30. And this has been increasing, and it continues to increase. And this category of severe obesity is going up the fastest. So it's an epidemic. We have to continue to work on it. If we think about what's a normal cholesterol, I like this little graph. So this looks at hunter-gatherers. These were people who did not live in industrial societies. And what you can see is that none of them had a total cholesterol over 150. None of these societies. And an estimated LDL was between 50 and 75. These are not people taking medicines. These are people living sort of out in the community. If you look at the average American, our total cholesterol is around 190. When we're born, our LDL is 30 to 50, and if we increase, when we start eating sort of the way we do in America, it goes up to about 160. We know that lowering your LDL matters. It doesn't matter how you lower it, whether it's with a medicine, with diet and lifestyle, you have a reduction in cardiovascular events, and this shows both of those. And if we look at total cholesterol greater than 200 in the United States, we have a lot of our population, almost 50% is a total cholesterol over 200. If you look at why LDL lowering matters, these are people who have familial hyperlipidemia where they have very high LDLs and they start getting cardiovascular events at a young age. Some of these people in their teens. These are the individuals we see with LDLs in the 300 to 800 range. And then the higher your LDL over your lifetime, the earlier you start having cardiovascular events. And so if you're thinking about optimal health, you really want the lowest LDL that you can attain over the longest period of time. Healthy lifestyle reduces atherosclerotic disease and lipid levels. So if you look normal weight, normal blood sugar, reducing simple sugars and refined carbs, and increasing physical activity all improve your lipids, and they improve them in the right ratios. If you look at our guidelines, and I think this is really important, we have guidelines in the United States and in Europe, and for patients that have established atherosclerotic cardiovascular disease, we put them into high risk and very high risk. Sorry, at risk and very high risk. Anybody who's had a prior cardiovascular event, anybody who had a recent MI, anybody who had a peripheral arterial disease is considered at very high risk, because we know the likelihood of having recurrent events is very high. And because of that, our guidelines have just changed to recommend LDL less than 55, which is what the European guidelines have been recommending for the last 3 years. Ours has been 70, and there's new documents out on that. We do a really bad job in the United States. This is the GOLD registry, which looks at lipid control in patients at very high risk when the goal was 70, and less than 1/3 of patients got to goal. It followed patients who came into this registry for 2 years who were not at goal, and only 17% had any intensification of their lipid-lowering therapy, even though we have 4 classes in addition to statins now. So lipid control becomes really important, and it's not done well. Hypertension is also common. Obesity, physical inactivity, increased salt, diabetes, moderate alcohol, and postmenopausal state all increase our risk of developing high blood pressure. I think it's important to know that home blood pressures correlate much better with cardiovascular metrics than office blood pressures. So if you see an elevated blood pressure in the office, we always ask patients to check a blood pressure at home. And if we have a healthy lifestyle, like a normal body mass index, daily activity, and a DASH diet, it treats high blood pressure, but it also reduces the likelihood of developing high blood pressure by 50%. So that should be encouraged to everyone. And then the other things that lower blood pressure we've already talked about: weight loss, diet, sodium reduction, and really it's processed food sodium reduction. It's not salt added at the table. Supplementing potassium, increasing physical activity, and then reducing alcohol levels to less than 1 drink a day. Abnormal glucose is the norm in cardiovascular patients. Less than 1/3 of patients who have ASCVD have normal glucose metabolism. And so it's important that we check A1Cs at least once a year to know that, so we can steer our patients the right way, because we know once they get to that type 2 diabetes point, they have an increased mortality. There's lots of different pathways of elevated risk for diabetics, and they include not only the cardiometabolic effects, but they also have increased thrombosis. And so there was this guideline that just came out from the American Heart Association. It's phenomenal. If you haven't had a chance to look at it, I would recommend. And it's the Comprehensive Management of Cardiovascular Risk for Adults with Type 2 Diabetes. Because for the first time since metformin, we now have 2 classes of medicines that have been proven to lower cardiovascular death rates in patients with diabetes. And so it has to be a team-based approach. This can't be left just to the endocrinologist. And basically that's what this document says. And it says it includes lots of things, but physical activity is important. You should get weight training as well as aerobic activity. You should have a tailored nutrition plan as a key component, and there's no perfect diet is really what this says. It says there are lots of diets that have been studied, and there's a lot of information. You should control weight. If your patient has a BMI over 40, they should be recommended to consider metabolic surgery, and they have failed weight loss attempts. This is strongly worded in here. If your BMI is 35 to 40 without improvements in weight loss, you should be referred to surgery. And if it's between 30 and 35 and you have type 2 diabetes and other cardiovascular complications, you should consider it. So I think we don't do that very much. If we get a target of less than 7%, we reduce cardiovascular risk by almost 40% over the next 11 years. So that becomes really important. We're in the same with diabetes. We do not do well in the United States. The prevalence of reporting sleep of less than 7 hours a night is almost 50% of our population of adults. And if you look at this in all-cause mortality, people who got more than 7 hours of sleep had the lowest cardiovascular mortality. So it becomes important. And then the last thing I want to mention is adverse pregnancy outcomes. So we know that about 30% of women have adverse pregnancy outcomes. What is an adverse pregnancy outcome? That is preterm delivery, gestational diabetes, gestational hypertension, preeclampsia, eclampsia, fetal growth restrictions, or very large babies. Those are all considered an adverse pregnancy outcome. And we know that group of women have a higher risk of cardiovascular disease in their lifetime, and we should start screening those women earlier and be more aggressive. Maternal mortality is increasing in the United States. It's an epidemic and it's embarrassing. We are the worst country in the industrialized world for maternal mortality. And if you look, cardiovascular disease is the leading cause of death in the pregnancy and the postpartum period. If you look at cardiovascular mortality, it's going up, pregnancy-related mortality, it's going up, not down. So that's a bad thing. And most of them happen either right after pregnancy or in the what we call the fourth trimester, those next 42 days after pregnancy. And so racial disparities are high in this group. It affects women of color, Black women significantly, and Hispanic women are at higher risk than white women. Preeclampsia is bad. You have a 70% increased risk of cardiovascular mortality over your lifetime. The fourth trimester is this 42 to 365 days postpartum, and we should think of not only pregnancy, but those women that present afterwards and look at optimizing their risk. Because of this, in the 2018 lipid guidelines, we included this as a risk-enhancing factor for the first time. This is the first gender associated. So all of our women, we should be asking this. Have you had premature menopause, a history of pregnancy-associated conditions, or preterm deliveries? So key takeaways: optimal lifestyle is rarely seen in the United States, but we're all working to change that. And I agree with Ed. I think it's a combination of pharmaceuticals and then patients who are interested seeking out other approaches to get to the best life. Improving lifestyle is essential to optimal health, and then control of risk factors is key. Thank you.
All right, good morning. My name is Josh Porter. I am the clinical director for Optimize U Chattanooga, and forever in debt to Ed Jones. My office location is on the lower level of Nutrition World. And thank you, Dr. Bailey, for kind of bringing up some of the things that really led, just so you guys have a background of why Optimize U exists, is I worked in corporate healthcare for 11 years, and it was the very stark truth that we're not doing that great of a job, right? Not providers, but overall in our society, when you look at the data, optimal lifestyle is really not where we want it to be. When you look at the data, obesity is not where we want it to be. And so I had the question of, is there something else that I could do in my control that I could kind of step out of maybe the traditional box of medicine and look at this from a different way? And so Optimize U exists with a focus on hormone optimization. And so we're going to talk a little bit about that. Hormone optimization is a pretty controversial, topic for a lot of providers. There's a lot of misinformation, to be perfectly honest with you. There's not a ton of great education. There's not fellowships and things of that nature that really dive in to this topic. So much of what we do in many ways is self-taught. And it is, again, self-taught out of a desire to see something different in our culture, in medicine, that has kind of led us to this. So we're going to talk a little bit about hormone benefits. We're going to talk about those controversies, and we'll kind of look at where we are now, okay? So hormones are vitally important. If I've got any women in here who have gone through menopause, you can give me an amen, because when you go through menopause, or when men go through andropause, that when you lose those hormones, life changes. And so we know that hormones are important, and there's just a list of things. It helps with metabolism, it helps with DNA, it helps obviously influence gender. It helps with mood, sleep, and things of that nature. It helps with energy levels. And we also know that sex hormones do more than just sex, right? So a lot of times people with estrogen and progesterone and those things, what are those components that these hormones play a role in? And these are just a few. Estrogen has over 400 functions in the body. One of those would be brain health, right? So if you look at some of the data, as women age, estrogen falls, Alzheimer's, dementia rises. So we know that some things, when it comes to sex hormones, play a huge role in things like helping with the immune system, helping control diabetes, helping with cardiovascular disease, helping with fatty liver. And so it is a very narrow mindset to think that hormones or sex hormones just play a role in gender and sexual function. But here's the issue. We have a couple problems when it comes to hormones. Number one, whether we like it or not, we all are going to face hormone decline. Some people will say that we don't lose hormones because we age, but we age because we lose hormones. And so the reality is, as Father Time, as Ed said, Father Time can be kind of cruel. Once we kind of, start to hit our 40s and 50s, our hormones are going to decline in some manner. And so when you look at somatopause just means growth hormone deficiency. Obviously, menopause, andropause, gender-related. Stress plays a huge role in our hormone levels. Environment, xenoestrogens, phytoestrogens, and those things. We see more men, as an example of this, in their 30s and early 40s with low testosterone now than we did 20, 30 years ago. And much of that is a contribute to our environment, to the things that we put in our body, to the things that we're exposed to that actually help to decrease our testosterone levels. And then here would be a little bit of my soapbox, and this is, again, going a little different direction maybe than the traditional medical model, is we just don't get it. Normal is not optimal. And when I say that, what I mean is when I have a patient in front of me, and this doesn't apply to every lab value, but there are some lab values that somebody can be within the normal range and still be symptomatic. And so I would encourage you to kind of think outside the box sometimes. And that may not be something in your practice that you can do, because a lot of us are constrained by insurance. But that's one of the reasons we created what we have at Optimize You, is because we have the ability to kind of step outside of the traditional medical model. The other issue is media influence. I'll kind of explain that a little bit. So 2013, 2014 is an example, and I'll throw up these studies here in a minute, but the media really gave testosterone replacement a black eye. It became something that, for all intents and purposes, was, if you went to a testosterone clinic, you're, getting anabolic steroids and you're the next Arnold Schwarzenegger. And the reality is, it's just not what the data shows. And so, but, we've gone through a pandemic where media influence is pretty powerful as well. And so I think we as healthcare providers are called to a little bit higher standard of where do we get our information? And I would encourage you to kind of question those things when you're deciding on, what is truth and what is false. So here's a common view, and let me give you, I'll explain a quick story. It was perfect timing. So yesterday I had a 52-year-old female who came into my office, partial hysterectomy in 2018, felt pretty good, so both ovaries were retained. She felt pretty good for a couple years. About a year ago, she started getting symptoms, and when I say symptoms, you think of it, she had it: brain fog, weight gain, vaginal dryness, low libido, anything and everything, hot flashes, night sweats, so on and so forth, right? And I could tell, I always tell my patients one thing that I really take pride in is the first thing they always want to ask me is, hey, what do my labs show? And my response is, I have no idea, because I don't want to know. I want to know, what are you here to see me for first? I want to listen to you, and then we'll use what you tell me combined with those labs to kind of figure out what's going on. So after she asked that, I could just see in her disposition that she was a little bit uncomfortable. She had her arms crossed, and she said, well, I just want to make sure you understand, and I hear this all the time. She said, I don't really believe in hormones. She said, I don't really think that hormone replacement's necessary. She said, I think this is the way we were made. We're supposed to age, and just go through it. and not take hormones for it. And I said, listen, my job is not to convince you that you need hormone replacement. My job is to educate you and to give you some varying viewpoints. And I said, let me ask you this. If we know that when a female goes through menopause, there's a couple things that can happen, right? Osteoporosis, cardiovascular disease rises, diabetes increases. I said, so 15 years from now, your doctor tells you that you've got osteoporosis. Are you going to take a bisphosphonate? Are you going to take Reclass? Are you going to take Forteo? What about cardiovascular disease? Are you going to get on a statin? Diabetes? Are you going to take metformin? And she kind of looked at me and was like, well, yeah, why wouldn't I? And I said, well, my whole purpose of trying to help you understand this is if we take hormones, there's a great chance, based off what literature shows, that we can lessen some of those risk factors. So you choose. You can choose to treat menopause with statins and blood pressure medication and diabetes drugs, or we can try to offset some of that with estradiol or progesterone. It's up to you, right? And so, again, it's in an effort not to say, hey, I'm always right and you're always wrong, but to say, I just want you to think about something differently. And here would be my view, and this kind of goes into how I said it, is that, yes, I agree. Aging is a self-destructive process. We were put on this earth to procreate, whether we like it or not. Once that system is set and done, we start to decline. And so we go through this self-destructive process. So it is a natural process, but the question is, just because it's natural, is that what's best for us? And I think that would be where I would disagree with some colleagues, perhaps. This is another misconception, right? So, women, and men think that, hormone replacement automatically means that, this is what I'm supposed to look like, which is just, obviously not accurate at all. Just a little glimpse of kind of the female ovulation cycle, and just kind of so you can kind of see. This is normal. So you see progesterone. This is showing the LH surge and progesterone heighten, and in preparation for implantation of the embryo. This is perimenopause. So one of the things that I pull this up for, breast cancer, for example, is bimodal. One of the reasons we see it as bimodal is because it starts to increase around our 40s or perimenopause age. Well, the question is why? Well, one of the things that sticks out to you on this chart, or should, if you compare it to the last one, it's not really estrogen. Estrogen doesn't really change there, but if you see, progesterone goes down substantially. And perimenopause, for the most part, up until later on, closer to menopause, is really a progesterone deficiency, not an estrogen dominance, right? And then you guys flatline, all my women in the room. So that's when, obviously, we have the discussion about progesterone and estradiol. And again, let's talk about women killers. Cardiovascular disease, osteoporosis, you guys probably know a lot of the statistics, dementia, breast cancer, all of which are rare prior to menopause. Now, I'm not saying that menopause causes all of those things. That's obviously an association. But we know that menopause and losing those hormones doesn't help us. The first three of those are typically due to estrogen deficiency. And then the breast cancer is typically due to a progesterone deficiency. And so hormone optimization really focuses on protecting and preventing a lot of disease. I tell my patients all the time, there's two things I'm trying to do. I'm trying to fix your symptoms, whatever those symptoms are that bring you in. And in the back of my mind, I'm thinking, what does the next 10, 15, 20 years down the road look like? Quality of life matters. And when you look at women with hormones, and this is another topic for another day, but women with hormone replacement, the number one thing they're always worried about is breast cancer. But the likely thing that's going to kill you is not breast cancer, it's cardiovascular disease. Going to get all of us, right? 33% of the cause of death is cardiovascular disease. Breast cancer has a 90% prognosis of getting through it. So from the standpoint of what's the likelihood of you dying from breast cancer versus cardiovascular disease leads, all forms of cancer astoundingly. And where does the breast cancer debate come from? And I throw this up here, the WHI trial in the early 2000s, late 90s, a lot of issues with that study. one of the things, well, several things. Number one, the wrong patient population. The mean age of that patient population was 63. Women were 10 years plus outside of menopause. They were asymptomatic. And in some way you can understand that because they didn't want to give women who were asymptomatic something placebo, symptomatic placebo. It was the wrong medication. It was Premarin and Provera, which we typically don't use anymore. So, you know, we can't, it's not apples to apples. Literature is pretty clear about that. And it was the wrong interpretation. So anytime you see a relative risk, you should always ask, what's the absolute risk? Well, in the relative risk and in the media, you saw this 25, 26% increase in breast cancer. Oh my God, like, are you kidding? 26% increased risk in breast cancer? But the absolute risk was without this combination of Premarin and Provera, 4 out of 1,000 women. With the combination, it was 5 out of 1,000. So not to minimize it, but again, 25% sounds much cooler than an absolute risk of 1 out of 1,000. All right, let's talk about men. So, if you guys know Joe Rogan, Andrew Huberman, they help my life. They you know, speak on these topics a lot. Men love these two, and so it's pretty common that somebody's heard about testosterone with men from one of these guys. Life is a little bit easier, a little bit more gracious to men as we age than it is to females. Females, they go through the menopausal period, and then it kind of drops off a cliff, like you don't have it, right? Estrogen, progesterone's gone. It's a much more steadily decline for us men, but you can see as time goes on, as we age, we know that testosterone levels are going to decline. So it's not a matter if someone becomes symptomatic, but rather when. Here's some data. It's a busy slide, but the take-home message of this is that testosterone deficiency has been projected to be involved in the development of 1.3 million new cases of cardiovascular disease and over 1 million cases of diabetes and 600,000 cases of osteoporosis-related fractures. This is a big deal, right? This is not something to just assume, oh, you know, it couldn't be that. But here again, here's some controversy. Well, I thought testosterone caused DVTs, blood clots, and strokes. Out of the past 60, 70 years, there's been 2 studies, both of which I'm referencing here, Vegan and Finkel. They're retrospective observational studies, which are weaker studies. It's not a randomized controlled trial, and both of which have some major flaws. The Finkel study is an insurance database, so they looked at here's, you know, a group of people who were given a prescription of testosterone, here's ICD-9 codes at that time, and they associated that, wow, guys who had, you know, prescription of testosterone had a higher incidence of these diagnoses based off the ICD-9s. But we have no control. We have no idea if the patients took the medication. We don't know if they got to a therapeutic level. How were they managed? And then obviously we know miscoding can occur. The same thing with the vegan study. It was supposed to be an all-male study. As they went through the data, they realized that they'd actually included 100 women. So there's just some errors in the study, and it's not strong data. So as a result of these, just so you know, there now exists a black box warning that the FDA placed on testosterone that says, hey, guess what? This can happen, and so that scares patients to death, right? So when that occurred, 29 medical societies actually wrote to JAMA, which put one of these articles in, and said we would suggest that you remove this article, which they did not. But when you have that many medical societies saying, hey, this is trash, I think you probably should take note. So as a result of that, we've had a couple, Abraham Morgenthaler as a urologist in Boston. He produced a meta-analysis, which is, again, kind of let's look at the data over the past 60 years. Here's another study. And basically what it showed was that there is no evidence of increased cardiovascular disease in this particular trial. What this study showed is that not only is there no increased cardiovascular disease, but men with lower testosterone levels tend to have higher cardiovascular risk. They tend to have higher all-cause mortality. They tend to be sicker individuals, so they tend to be hospitalized more. And men who are on testosterone also has a higher ability to enhance glycemic control. So we can get to the root of the problem oftentimes by administering testosterone to somebody because we can decrease visceral fat. Now, it's not metformin, it doesn't work tomorrow, but it is definitely something that long-term shows very promising studies. So where are we now? Obviously, I think controversy still exists, hence why my practice is here. But I think there's extensive literature over the past 50 years that shows great benefit with little to no harm, and I think that's pretty proven. I think one of the encouraging things that I have seen as stepping out of corporate healthcare and going into a different direction of a cash pay practice is patients are taking more control of their health, right? One of the reasons I partnered with Ed was because he has established that type of culture where people are engaged in making sure that they are taking care of their health. And so no longer do I feel like it's this obligatory, you know, oh, I need you to do this. Patients really come to me wanting to know. They're engaged, they're educated, and it makes practicing medicine a lot more fun. And then our job, like I said earlier, is not to dictate what the patient does. It's to provide education, right? I think the more we can educate patients, it's on a pretty routine basis. I'm emailing patients, I'm sending them resources. Again, not so that I can say, hey, I'm right, you're wrong, but to say, hey, why don't you read this and let's talk about it? Because that's the only way you can, moving the needle forward in an effort to control diabetes is we've got to educate people better. And then I think gone are the days that patients assume that everything we as medical providers say is, you know, the gospel. I think we can all agree that that's probably out the window. And I think the more we can accept that and be willing to say, you know what, there's times I don't know the answer to that. I had a patient yesterday, she's asked me about parathyroid. I didn't know the answer to the question. I said, look, I promise you, I'll look this up. We'll get back in touch. I have no problem with doing it. And I think patients are engaging us more when we have that ability to say, you know what, I don't know, but let me find this out. If you don't move, it's not my fault. Okay, just letting you know. Motion is lotion. Motion is lotion. I'll give you another 20 seconds to move. And I will probably move, and my voice is usually enough for people to hear. The AV guys don't like it because then it doesn't record very well. Sorry. This is not particularly worth recording anyway. Trust me, you'll see what I'm talking about. So, your 20 seconds is almost up. Let's see if this is what advances a slide. Is it the arrow button? It does. Good. So this is me, Vital Life Medical Care. This is the landing page on my website. I'm not going to bore you with my bio. If you really want to know about me, you can go there and read about me, and then you will have done it because you wanted to. At the bottom of that site, you will find my contact information. So if you'd like to email me or voicemail me or text mail me or call me, please feel free. All right? So there is a Mark Twain, wonderful guy, and there's a wonderful old saying of his, which is, where do I point to make it go? So I don't know what you think you know for sure about the mind-body connection. I'm not sure what I know for sure about the mind-body connection. But one of the things I do know for sure is that we all know information doesn't really change us. If we want to change, we need an experience. Yes? Right? So that's what I'm offering you today. I'm offering you an opportunity to choose to experience something. So let's talk about that for just a minute. I have a financial disclosure to make with this company, Vision Pursued. This is the nation's leader in the industry of something called performance mindset training. If you choose to visit their website, I predict you will be duly impressed with their clientele. The reason I have a financial relationship is because I have a personal relationship, and that's because prior to the pandemic, I was suffering from burnout and moral distress. And when the pandemic hit, it brought it to a rolling boil. And I had to do something, or something bad was going to happen. I'll circle back to that later. One of the things that I did was this company came into my field of awareness, and I participated in their mindset training.
and it had a profound impact on me. So the material you're going to see is their proprietary information that's being used by permission. And your experience starts with this first question. If you were to think about your day and just your personal day, what percentage of your day would you say was experienced as stress, monotony, or escape? And by that I mean, all right, it's your free time now, and the first thing you do is go to Netflix, or go to Instagram, or go to the bar. You're not really experiencing your life, you're doing something else to escape your life. What percentage of your day would you say is monotony, stress, or escape? What percentage of your day would you say you experience as, I feel good, right here, right now, I don't need anything else to feel good? If you are like me, and you're like tens of thousands of people who answer that question, you typically come up with a graph that looks like this, somewhere in the 70-30 range. About 70% of our day is experienced as stress, monotony, and escape, and about 20 to 30% is when we feel good. So, you have another thing that you already know to be true, which is if we really want to change, we are going to have to measure. If we are not measuring, we are not going to change. And we also know that in typical, if we're not recording, we're not measuring, which is why your worksheet is on the table in front of you. Please find your little worksheet. Looks like this. Has my thing at the top, Vital Life Medical Care. Has a couple of typos on it. I'll apologize for those as we go. But you're going to want to get that out. And the next thing you're going to want to do is you're going to want to ask yourself, bring to mind the thing in your life that's currently your greatest stressor or challenge. It can be personal, it can be financial, it can be professional, but really let yourself ask, what is my single greatest stressor or challenge right now? And then on that scale, 1 to 10, how heavy or light does it feel? Light would be 1, heavy would be 10. You can circle whatever number looks best to you. How heavy or light does it feel to you right now? Now, as you think about that stressor or challenge, let yourself imagine a bad outcome. If that stressor or challenge works out in a way that you think is bad, what does that look like to you? Jot down a couple of words, half of a sentence, or something. Again, if you don't record it, you're not measuring it. If you're not measuring it, you're not going to change it. This is your experience, though. Do whatever you want. I didn't pay to be here. You did. So, if that thing doesn't work out the way you want it to work out, and it's bad, what does that look like? Give you just a moment with that. As you're finishing that up, let yourself imagine a good outcome. Or said another way, now if this could work out ideally for me, the way I think I really want it to work out, what does that look like to me? How does this work out if I really get what I want? And just jot down maybe a few words, half a sentence. What does that look like to you? What's that experience for you in your mind's eye? And as you're finishing that up, let me invite you to kind of look back over your own life's history and ask yourself, have I ever experienced a situation where I thought this outcome was bad and it really turned out to be neutral or maybe even good? The so-called blessing in disguise. Just have you ever actually personally experienced so-called blessing in disguise? I thought something was going to be bad, and lo and behold, there was this whole other good thing that happened. Have you ever experienced the converse? Man, this is going to be great if it works out this way. I really got what I wanted, and or maybe, darn, that's not going to work out at all. Have you ever had a good thought that turned out the way you wanted it to, and your experience of it was actually neutral or bad? Have you ever actually had a life experience of that? Most people say they have. So let's circle back now to your bad outcome. Let yourself go back to your bad outcome. Kind of bring that picture back up, that bad thing that was going to happen if it worked out that way. And then ask yourself, what am I or the people around me likely to feel if that outcome happens? What would be some emotions, what would be some emotional feeling experiences I would have if that outcome emerged? And you might just jot down 1 or 2 feeling words. By the way, here's a free tip for the day. Kindergarten feeling words work better. Like sad, mad, glad, afraid, anxious. Simple kindergarten words work better. What would I feel, or what would people around me feel if that bad outcome happened? Now, oh wow, I'm back, audio video people. Sorry about that. Ask yourself, and you can drop down now to, that was actually under the section called expect the expected. It says unexpected, but you can cross out un, it's expect the expected. And you can drop out to separate, embrace, evaluate. And separate is misspelled. It should have an A, not an E after the P. My apologies. My mother's an English teacher. She would be groaning if she knew. Although I will tell you I had help making this form, and I just printed it off quickly before I proofread it. And it's my fault for not proofreading. Anyway, if you drop down to separate, embrace, and evaluate, and you ask yourself, that negative emotion you were just feeling, why would your brain do that to you? Why would your brain make you feel bad? Because you did. You felt bad. When you thought about the outcome and you felt sad, you felt sad. There's a mind-body connection there. Why would your brain do that? It would do that because your brain cares about you. But it's important to know that it was your left brain that was doing that for you, particularly your left limbic or amygdala that was doing that to you. And the reason it did that is because your left brain wants you and me to learn from our past mistakes and not repeat them. Period, end of story. We survive better. We have less heart attacks and strokes, less diabetes, less pre-vascular, morbid everything if we learn from our mistakes. Or as Osler said, take time to learn from others' mistakes. You don't have time to make them all yourself. So we want to learn from our mistakes. That's why your left brain projected neurochemicals to make you feel bad. Ask yourself this question. Was that useful? Was it useful for you to feel bad? It was a negative experience. Was that helpful? Maybe ask yourself this. What if that bad experience really did emerge and my brain did not alert me with a negative feeling and it told me to feel good about a bad outcome? What if my brain were doing that instead? So the neurochemicals are there to help you. They're useful because they want you to learn and avoid same mistakes. So, I don't know if we can bring the lights down even a little bit more somehow, but if you'll, while they're trying to do that, if you'll kindly put your pen down. Kindly put your pen down. If you're participating in experience, feel free to do whatever you want with your pen if you've chosen not to participate. But if you're choosing to participate, if you just look upon this picture and give yourself permission to observe. Just observe shapes, shades, general color, general objects, the mood that it seems to communicate. Give yourself permission to not label, to not categorize. Thank you, that's perfect. Just stay in that observation mode. Shapes, colors, textures, mood. Stay in that mode for just a minute. And try to give yourself permission to just stay light. Try to use as little effort as possible. Try to let yourself just observe the picture. And then, if you will, close your eyes. Try to keep them closed until I invite you to open them again. It won't be very long. And see if you can give yourself permission to relax. Here's a great way to do it. See if you can bring your attention to the surface upon which you are currently sitting. See if you can let yourself notice the chair beneath you, your feet on the floor, the back of the chair against you. See if you can begin to notice the movement of your own breath. Can you notice where you notice your breath? If you can, see if you can choose to exhale just a little longer than your inhale. Next time you take an inhale, Try and allow the exhale to be just a little longer. Maybe take one or two more of those breaths where you letting your exhale be just a little longer than your inhale. And see if you can begin to notice the sounds around you. Let yourself become aware of what you are hearing and give yourself permission to not label them. Simply hear and observe the sounds around you. Try to stay in that frame of mind, that observation mode. And when you open your eyes, you can go ahead and open your eyes, looking at this screen, let yourself observe what colors, what textures, what shapes, what energy, what mood. If you find yourself worried that it's not working, relax. Put less effort into it. Let your eyes get the wide-angle view of the picture. Try to take in the entire thing and then see, where do your eyes naturally want to roam? Let them roam there. And if you can, gently place your left hand on top of your right hand so that your left wrist lays on top of your right wrist. Just gently. And continue to let your eyes roam wherever they will. Take in the wide angle of this. Really see the whole thing. Allow your eyes to roam where they will, noticing shapes, textures, shades, colors, energy, mood. Simply observing. Simply observing. Allow yourself not to label or categorize. If you're finding yourself doing that, try less hard. Relax. Staying in that observation mode, left hand crossed over right so that your left wrist is on top of your right wrist. Take in the wide angle of this picture. Then allow your eyes to drift where they will. For no reason whatsoever. Where do my eyes just naturally go? Now, staying in that frame of mind, which one of these pictures was most appealing to you? Let your eyes go there. Whichever one just rang for you the most, go there now. Put all of your focus on that picture. Staying in that observation mode, I'm going to ask you a few questions, and I would encourage you to simply allow whatever just spontaneously arises to arise. All of your focus on those pictures. Ask yourself, I wonder why that one stood out to me the most. Staying in observation mode, what mood or energy emerges? Are there any memories or associations? Staying in spontaneous mode, if I ask you, if this picture could talk to you, what would it say? Staying in spontaneous observation mode, if I were to ask you, what should you do about that challenge or stressor? What pops in your mind? What should you do about that challenge or stressor? Now, if we can bring the lights up a little bit, you can find your pen, and you can jot down for just a minute what you think you should do now about that challenge or stressor. You can even bring up the lights a little bit more as you're writing down what you think you should do about the challenge or stressor. That was your right brain talking to you. It looks at the world very differently than your left brain. Its point of view is, maybe I should give the world a break. Maybe I should give people more margin. Maybe I should give people a second chance. Maybe I should not jump to conclusions. Maybe I should wait until all the data comes in. That's its posture. Because it's okay with exploring the world. What's most important is, if you had any sort of shift in what you thought you should do and what you thought you should experience when your left brain had the microphone, as opposed to what you thought you should do or what you were experiencing when your right brain had the microphone, if you compare those two, what you just experienced was a shift in something in the neuroscience literature called brain balance. Brain balance. Andrew Huberman will tell you a lot about brain balance. Lots of people will tell you a lot about brain balance. What's important about brain balance is, if you were like me and you fell into that 70-30 split initially, if you can find some way to generate more brain balance in your life, you can expect this to happen. You can expect to go to 60-40, approaching 50-50. And the studies are crystal clear. When a human being shows up brain balanced in their life, it drives behavior change. Or said another way, if you really want to change your behavior, you're going to have to balance your brain. And that's the question, isn't it? Why is he up here talking to me about brain balance? What in the world does that have to do with vascular care? Precisely this. I mentioned burnout and moral distress. Everybody knows burnout and all the components. You're exhausted, you're disconnected, and you don't find meaning in what you do anymore. You're burning out. Moral distress, not quite as clear, but it's more rampant, by the way. Moral distress is when you are feeling compelled to do something that goes against your ethic, or you're feeling constrained to not do something that you think is ethical by the powers that be. The difficulty with moral distress is it's not static. It leads to something called compassion fatigue, from which I was suffering dramatically. Compassion fatigue is simply this. Actually, it has only bad outcomes. If you are suffering from compassion fatigue, like I was, you will either stay in your current job and be worthless. You will just be a curmudgeonly, old, crotchety, unpleasant person to be around, or you will make a mistake and the patient will pay for it. Right? The fourth leading cause of death is medication error in this country. Fourth leading cause of death. Or you will take your own life. Every 18 hours in America, a physician takes their own life. 200% more than any other demographic. That's called compassion fatigue. Would you like to know how, if you have compassion fatigue? I'll tell you how. It's a very simple test. If someone else's sad story tends to make you more mad than sad, here's your sign. You have compassion fatigue. So, what that has to do with you as a vascular care provider is simply this. The most important tool in your kit is not the latest, greatest laser. It is not the coolest stent. It is not the study that shows 2% improvement in all-cause mortality. The most important tool in your kit, if you really want to be a high-end vascular care provider, is you. You are always more powerful than the procedure. You are always more powerful than the pill. You are always more powerful than the study. And the only question is, and this really is the only question, so if I lost you, come back. It's worth hearing this. What are you going to do to take care of you as you try to take care of those others? I would encourage you to find some way to improve your brain balance. If you'd like to talk to me more about any of those things, again, this is where you can find me. I thank you for your kind attention.